So again, my name is Vache Hambardzumyan. I'm orthopedic spine surgeon at Monadnock General Hospital. We do general orthopedics as well as we establish spine surgery service and spine care service. So we are taking comprehensive care of all spine problems, including physical therapy, injections, and most top-notch cutting-edge technology surgical procedures. Thomas Quinn is my PA. He's here for your questions also if you have any after the presentation, as well as I'll be available for any type of questions. So I'm going to start with a brief introduction about spine care, why it's so important for us, and why it's getting more and more common in current day medical practice. So if you look at these numbers, almost 80% of the patients, and I would say 100% of the patients, of the people, they experience at some point in their life low back pain. And all of us, there is no one single person who never experienced back pain in his or her life. And if you look at this number, 1 to 2% of US population, they are disabled because of back pain or any spine issues. So 1 to 2%, it's approximately 6-7 million. It's a huge number. And 6-7 million people only disabled with the spine issues. I mean, you would agree with me that it raises certain awareness. And if you look to overall PT, physical therapy patients, physical therapy referral, almost 1/3 of PT referrals are spine patients. So it's something really, really common. So this is a study published recently, and it shows that yearly over the 85 billion of healthcare costs are allocated to the spine, which is a really huge number, and this number is increasing. Interestingly, proportion of the elderly patients undergoing spine surgery is increasing even more faster. Why is that? Why more people after 65 having much more spine surgeries than before? Look at these guys. So they are exercising. Life has changed with advances of technologies, with advances of medicine. Much more people, they are active at 60, 65. Much more people, they are jogging, cycling, hiking when they are 70. And much more people, because they are in good health with regards to their heart, their lungs, and they have, in general, great quality of life. They want to be active much longer. And now, 65 years old people, they do same as like 20, 30, 40 years ago, 45 years old would do. And they are not working hard, they are retiring early, they want to enjoy their life. And of course, with all this, spine is letting sometimes spine is not letting them do as active as they want to be. And then we are having a high rise of spine surgery cases with elderly people. And another key thing which I'm going to talk a lot about this is minimally invasive surgeries. So before, again, and probably you have the same stereotype about the spine surgery, that it's a big incision, long recovery, chance of paralysis, and lots of complications. But again, things are changing with new technologies. We have devices, we have tools which we didn't have like as short as 5-10 years ago. We have new tools which allow us to do the same big surgeries with minimally invasive technique. And I'm going to talk about that more. So before we used to do like 5-6 inch incision, now we are doing the same surgeries with only half incision surgery. Half-inch incision surgery. So imagine the difference. This one and this small incision, like less than my thumb. So this changed dramatically what we can do, what we can offer to our patients, how we can improve the quality of life. So look at this number. Lumbar cases, they rose over 113%. So lumbar spine surgeries. When the same time, total hip or total knee surgeries, they rose only 13-15%. So look at this difference. This is a US trend for 10 years. so dramatic increase of lumbar spine surgeries. And look at this number. For people aged 60 and more, the number of lumbar surgeries or lumbar spine, or in general spine care cases, rose up to more than 300%. Now, this is general statistics. Okay. Now I'm going to move. I'm going to talk about a little bit about more like pain and complaints issues. So I want you to turn the page, and now we understand that there is a problem. We are dealing with it. Why is there? Now I'm going to talk about back pain in general. So for me, I always tell my patients, and I always just divide back pain into 3 simple groups. The first group is localized back pain. The back pain which is only in the spine, is not shooting, not radiating, it localized in the back pain. This is the most common type. We call it axial back pain. This is probably the most common, most innocent, however most irritating type of pain. And it can last long. However, again, it rarely causes significant issues. The other type of pain, which probably you know, also it's a shooting pain or sciatic type of pain, when we have pain shooting down to the leg or down to the arm from the spine. This means we have a nerve root irritation. This is sciatic type of pain. This is so-called second type of spine problem which we are dealing with. And the third type of spine issues, and you don't know about this one, and not many people know about this one, however, this is the most dangerous one. This is when the problem spine issues pushing on the spinal cord. And patients are experiencing, it's not painful, so that's why it's getting missed a lot. So patients are experiencing balance issues, they are experiencing dexterity issues, clumsiness, and they would say, you know, doctor, I'm losing my balance, but probably I'm getting old, or I'm having difficulties unbuttoning my shirt, or I'm falling, I'm dropping things, the coffee spoon or tablespoon I'm dropping, I cannot hold it, I cannot knit as I used to do, my handwriting has changed, I cannot, if I don't look, I don't feel the ground, and I'm losing my balance. So the onset is very insidious, it's gradually progressing, and the dangerous thing is that the changes which are happening is lots of time they are permanent, unfortunately. So we call this condition myelopathy or compression of spinal cord, and this is something which even a World Health Organization declared 2022, last year it was a year to increase the awareness of this condition which we call myelopathy, which consists of compression of spinal cord. And again, patients are oftentimes attributing that to the age, to getting old, or to general weakness. But indeed, with very simple maneuvers, procedures, we can treat that. Here, again, that's what I was talking about. Gait instability, fine motor skills are affected. The patients are having weakness and so on. I'm going to skip this one. Management. Okay, now we are turning the page again, and I'm going to give you a brief idea how we manage in general the spine problems. So now we know that we have a issue, lots of people want to be active. We know the 3 types of spine disease. Now, how we manage this? Do we do surgery at once? Yes? No? Of course no. Do we progress with invasive manipulations at once? Of course no. And the first and foremost treatment for any and all type of spine issues is physical therapy. Physical therapy, muscle strengthening, stretching exercises, core strengthening, abdominal strengthening, gait training exercises, nerve gliding exercises, lifestyle modification, such as weight loss, activity modification. So someone is telling me, you know, doc, I'm climbing Mount Monadnock 6 times per day and I'm having back pain every night. So it's a real life. I'm telling you, I've heard that. So I'm saying, listen, probably you should climb once daily because you are 84 now, and then probably you'll have less back pain. Yeah, it matters. Painkillers, Tylenol, ibuprofen, muscle relaxers, all these help. And lots of people, they are getting along with this. And lots of time, I should say probably 80% of time, patients are more or less satisfied with what we call conservative management. And that's what we do. We have here, you're going to have talk, Alicia mentioned, next week we have a presentation with our great physical therapy department having a presentation. And they have lots of tools, lots of exercises which are helping. And which patients feel very satisfied with. Swimming, cycling. Swimming is a great exercise. So I always advise my patients, if you have access to swimming pool, if you swim three times weekly, there's gonna be more than enough. Injections. This is the second line of treatment. Injection is when we put a steroid hormone along with local anesthetic around the spine, around the, I'm going to back, wait, where is this? Okay, let me talk about the injections later. So this is when we put a anesthetic and steroid hormone around the spine, and this the second line of treatment. I'm going to talk about that later. Yeah, I put this slide. I love it, and it's really important to look closely. So this graph shows the pressure on the discs in different positions. So pressure is 25 kg when we lie down, and it gradually increases when we stand up, when we stand backward, when we stand and bend forward. Now pay attention to this. How much is the pressure on the disc when we sit, bend forward, and how much is when we stand up? So it's twice more when we sit than when we stand up. So again, the pressure on the discs are twice more when we sit than we stand up. And lots of patients telling me, doctor, I'm a payroll assistant, I'm sitting all the time, why I have back pain? And I'm saying, you know, ma'am, this is the answer. You are sitting all the time. That's why you have a back pain. So our body developed by nature or by evolution or by whoever you believe in a way that when we stand up, it's because of the spine curvature, the pressure on the discs are distributed in a way that it passes through our hips, through our legs. So when we sit, it's not a comfortable position for the disc. So that's why I always advise stretching, standing up. This is the simple things about the desk ergonomics. I don't know, it's very simple, very helpful. See the wrong position, slouched forward, pressure here, shoulders, wrists are not well positioned, and hips are not well positioned, and here when they sit. This is the correct position. The monitors, how far should be from the eye level, I should face the top of the monitor. Here is 90-degree or standing up position. If you Google, you know nowadays, Dr. Google is the best friend, right? If you Google desk ergonomics, you will find lots of pictures like that. And it's very simple. At home, all of us, we are sitting, working at the front of the computer, or even knitting or watching TV. This helps. Now we come to epidural injections. This is the second line of treatment. Let's say we do physical therapy, we do activity modification, we adjust our lifestyle, still is bothering. What we do with a special technique under X-ray control, we inject a potent anti-inflammatory medication, which is a steroid hormone, around the nerve root. Around the spine, this is decreasing the inflammation, decreasing the swelling, and has great results. So we have a pain management team. these are my partners, Dr. McNamara, Sarah Neal, Dr. Harrington. They are dealing with this one, and they are great on their job. Excellent results, lots of patients. They are getting these injections every 3 months, every 6 months, every month, and living high quality of life only with these injections. So this is the second line of treatment. The next, when everything fails, we move to the surgery. So I will tell my patient, I'm very conservative, so we need to try everything and fail everything before progressing to surgery. I always tell my patients, I'm your last resort as a spine surgeon. So do whatever you can, whatever you think it's going to help. Let's try everything and anything before we progress with surgery. Do you have any questions so far? Okay, maybe later. So here in Monadnock, obviously, you know, we are a critical access hospital, and we are not able to take really major cases, like with blood loss, with severe, associated with severe disability and so on. So that's why we are concentrating mostly on the minimally invasive procedure, mostly on the procedure which require only 1-day admission or same-day discharge. And again, with the help of technology, with the help of our partners like big spine companies, we are able to achieve that. So first I would like to talk about the disc replacement on the neck. So let's say patients are having pinched nerve on the neck and shooting pain, or what is much more common, pinched spinal cord and those balance issues. You remember I was talking about. So we can do cervical disc replacement. So this is a high-tech, cutting-edge technology. We didn't have cervical disc replacement available like 15 years ago, and we definitely didn't have these great implants based on titanium, 3D printed titanium and ceramics, which we have now. So excellent results, maintains mobility on the neck, and nowadays FDA, you know, for FDA obviously, FDA approved cervical disc replacement for 2-level, even for 2-level cervical disease, which is great, and it shows that it has much better results than other procedures. Sometimes we do fusion, cervical fusion, when we fuse 2 vertebrae together. Again, with certain pathologies we do this. Now, it looks scary, but it's day surgery. Patients are having small incision in the front of their neck. It's like 2-inch incision. It's a day surgery. They come early morning, have a surgery done, go home same day. Usually very safe, very successful. And we have patients here that they love the results, and they love the flow and the care which they are receiving, and most importantly they love that they are not staying in the hospital and returning to their daily activities very fast. Lots of patients now, I'm going to explain, it's complicated, don't look too closely. Lots of patients are asking, doctor, am I going to be paralyzed, or what are the chances of paralysis when you work on my neck or spinal cord? Real valid question. And here's the answer. So we have a special tool when we monitor the spinal cord function during the surgery. How it works? Again, high-tech, cutting-edge technology. We have a special people, which we call neuromonitoring technician. They stick needles in the skin on the head, stick needles on the extremities, on the hands and legs. And during the surgery, they are sending the signals from here and picking the signals on the feet or hands. And guess what? These signals have to travel through the spinal cord, right? Like the electricity has to travel through the wire. So now the spinal cord is the wire. And if I'm doing something which is wrong, which I'm pushing on the spinal cord or irritating the spinal cord, the technologist can see on his or her monitor live, online, and immediately. and they are yelling at me, hey, stop doing what you are doing. Spinal cord is not happy, for example. So it's increasing the safety of the procedure. Okay? So with this technology, the chances of paralysis, yes, they are there, obviously, but much. I don't remember any of this case in my practice. So this we call neuromonitoring. Again, it works just monitoring the spinal cord signal during the procedure. Dysectomies. So, you know, the disc bulges, probably you have heard, oftentimes pinching the nerve, sitting on the nerve, causing the problem. Here you can see obviously the disc bulge, right? So imagine this is a side view of the spine, front of the body, back of the body. Those are the bones, and this is the healthy disc, and the bulge disc. And it's pushing on the nerves, this black gray stuff here. So what to do? Again, when everything fails, we remove it surgically. These are multiple discs. I'm just gonna skip here. I'm just gonna skip this one. I wanna show this one. This is what we are concentrating mostly, minimally invasive spine surgery. This is when we do the discectomies from teeny tiny incision instead of doing large incision. So this is how it looks. It's a tube, and this goes inside the spine. It removes the discs. We remove the discs. So this is a real surgical patient. Usually we doctors, we don't put these pictures for the general audience. Why? Because it's too graphic, it's not appealing. But here I decided I'll do it because what you see. So this is the head of the patient, this is the back of the patient, and this is the tube. This is the marked spine. We just did some drawing to mark the spine. And but you just see the tube. There is no wound. And through this tube, we do everything. It's like, I mean, Thomas keeps on fighting me. He said, hey, I don't say anything. Just go away. Give me a place. So there is only place for one person to see. It's so tiny. And we are able to perform the entire surgery with these small holes. Okay? And this one, endoscopy. This is even newer, even smaller. The tube is much more smaller, much more versatile, and we approach from different angles and do, again, the entire surgery with this minimally invasive procedure. And it's getting more and more, it's becoming more and more popular. When I started my spine surgery practice, I was trained in doing like major surgeries, big incision, lots of blood, lots of spinal cord exposed. But nowadays, no. We are moving away, and everyone likes that. Patients love that. Our anesthesiologists love that. My nurses love that because patients are happy. Patients' family love that. Their employers love that. They go back early. So everyone is happy. So this is another. So see, this is a graphic presentation. Small incisions and large incision there after open surgery. And oh, that's a great question. It's very short. So let's say if the same surgery done in regular fashion, a patient spent in the hospital 2 or 3 days. Their pain level is high probably for a week. Return to normal activities in 4 weeks. Return to athletic activities in 4 to 6 months. So return to job probably 2 months depending on the job. With minimally invasive, home same day, back to work after a couple of weeks, back to regular activities after 3-4 weeks. Very fast, very easy, much less traumatic, much less invasive. So after these surgeries, patients are going home same day. I mean, it's very uncommon for them to stay at night. Vertebroplasty and kyphoplasty. So you have heard about osteoporosis. Again, it's something very, very common with patients with aging population. In spite of all vitamin D treatment, in spite of healthy diet and exercise, which we routinely recommend for osteoporosis, still osteoporosis can cause vertebral fractures. So again, with the same minimally invasive technique, we can inject, you see this white stuff, this is a bone cement. We inject the bone cement into the bone, into the broken vertebra, and stabilize the vertebra after the fracture. Again, it's outpatient procedure. It helps dramatically with pain. Like patients after fractures, they are struggling. So usually I'm telling, if pain is not improving after 4 to 6 weeks, if it's really bothering, then we can do this minimally invasive procedure and inject cement and also get rid of pain. This is again one of the minimally invasive procedure. I like to show this picture also. This is a larger surgery. This is a lumbar spine fusion. Sometimes when it's necessary, I'm trying to avoid this as much as possible, but sometimes we have to do it. We have to fuse the spine to stabilize it. It's when there is an instability or after repeat surgeries, we put screws and stabilize it with the rods and stabilize the spine also with all these constructs. So here in our hospital, we are limited how big fusions we can do. So probably this is what I'm showing. This is the 3-level fusion. This is the most what we are performing here. But again, 85% of cases we are able to perform here successfully without any issues. And I believe, yeah, I think one more couple of talks about, again, minimally invasive. This is the answer to your question. So it's less trauma, smaller incision, prompt recovery, and quicker return to work and quicker return to the family, to regular activities.